Welcome back to Endo in a Bite. I'm Dr. Simbleveg, and this is part 2 of our focused 4-part series on primary aldosteronism based on the recent Endocrine Society Clinical Practice Guideline. In today's bite, we're zooming in on a critical pitfall. Medications and even potassium levels that can falsely suppress the aldosterone-to-renin ratio. If you're screening for a PA and you missed these, you might miss the diagnosis entirely. So let's break them down one by one because context is everything when you're interpreting the ARR. First, let's talk about hypokalemia. This isn't a medication, but it's critically important. Hypokalemia suppresses aldosterone secretion, which can lower plasma aldosterone concentration even in someone with autonomous production. So if you're screening a patient and they have a low potassium level, the result may be falsely reassuring. Aldosterone might appear low or borderline when in fact it's being pharmacologically or metabolically suppressed. Always replete potassium to normal range before interpreting aldosterone levels. Now let's walk through the medication confounders. The guideline organizes these into strong, intermediate, and weak confounders based on how much they can raise renin and lower the ARR. Let's go in that order. Strong confounders. Mineralocorticoid receptor antagonists like spironolactone and eplerenone, and epithelial sodium channel inhibitors like amiloride and triamterene are classified as strong confounders. Why? Because they directly block aldosterone's action at the receptor or downstream epithelial channels. That leads to significant renin elevation. Aldosterone may also rise, but the renin increase is disproportionately greater, so the ARR drops substantially. Also worth noting, drospirenone is a synthetic progestin with MRA-like effects. It can increase renin and mildly suppress aldosterone, again lowering the ARR. It's not formally categorized in the strong, intermediate, weak schema, but its effect is similar to MRAs and should be treated accordingly. Next are the intermediate confounders loop and thiazide diuretics. These stimulate renin via volume contraction and decreased renal perfusion. Aldosterone may rise secondarily, but not always proportionally. The result is a moderate reduction in the ARR, which can still mask underlying PA if not accounted for. Now for the weak confounders. ACE inhibitors and ARBs raise renin by interrupting the RAAS and dihydropyridine calcium channel blockers modestly increase renin due to blood pressure reduction. These agents typically cause a less pronounced lowering of the ARR, but in combination with other factors, like mild aldosterone elevation, they can still contribute to a false negative result. If ARR is borderline in a patient on these medications, retesting after withdrawal should be considered based on clinical context. Just a word about SGLT2 inhibitors. First, they raise renin, which can interfere with interpreting the aldosterone-to-renin ratio. Their effect on aldosterone isn't clearly defined in the guideline, but the key concern is that by raising renin, they may lower the ARR, and that can lead to a false negative result by masking the renin suppression seen in PA. And remember, in patients with CKD, SGLT2 inhibitors may reduce the risk of MRA-induced hyperkalemia. In summary, accurate ARR interpretation for primary aldosteronism requires correcting hypokalemia first and recognizing the impact of medications. Strong confounders like MRAs, ENaC inhibitors, and drospirenone can markedly lower the ARR. Intermediate confounders like loop and thiazide diuretics have moderate effects. Weak confounders such as ACE inhibitors, angiotensin receptor blockers, and certain calcium channel blockers have smaller but still relevant effects, especially when combined with other factors. Even SGLT2 inhibitors may mask PA by raising renin. Awareness of these variables helps prevent false negative results and ensures correct diagnosis. And that wraps up today's episode. A practical rundown of the confounding meds and factors that can lead to false negative results in PA screening. Missed a detail? No stress. I've taken the notes for you. Head over to www.easyendoprep.com to download the full summary and sign up for weekly pearls sent straight to your inbox. Thanks for listening. Remember, stay consistent and let's keep it bite-sized.